Hello, everyone. My name is Dr. Grant Turek. If you've been to some of our Neuro IDD webinars before, you may recognize me. It is my privilege today to turn over the microphone to Amy Bryn with the Child Neurology Foundation, who's going to be our moderator today for this webinar in transitions and epilepsy and IDD. And she's going to be talking with, Dr. Ann Tilton, Dr. Christina San Inancio, and Dr. Larry Brown. So without further ado, Amy?
Thanks, Grant. So appreciate being here with all of you. Very much excited to have a conversation about this very important topic of transitions of care for young adults living with intellectual developmental disability. Before I jump into some framing comments, I did just want to let all the participants know this is being recorded. So if you do need to step away, you can access it later. There will be a transcript provided as well. And I also really encourage this to be a conversation and not just a didactic presentation where we're talking at you, but please use the chat function. So as you hear one of our speakers say something that you have energy about, you want to dig in a little bit more, go ahead and pop that into the chat function. I'll be checking that throughout this hour, and we'll be populating some of those questions to the panel towards the latter part of our time together. If we don't get to your question today, don't worry. The staff will follow up with you via email to make sure that your questions are getting answered. So with that, I'm going to pop up my screen and just do some opening framing comments to get this conversation started. Okay. Can everyone see my screen?
No.
No. Let me do that again. Can you see it now?
Yes.
Okay, thanks, Larry. All right, so let's dig in here. I believe Larry, who's really been our cheerleader for getting this webinar today started, asked me to moderate because of my role with the Child Neurology Foundation. I currently serve as the executive director and CEO, and have been really proud of the foundation's stance as a leader on the transition of care issue, really for the last couple of years. For those of you not familiar with the Child Neurology Foundation, we really serve the neurology space as a collaborative center, a place where multi-stakeholders can come together to really elevate a conversation that's affecting all children that are living with a neurologic condition. So if you're joining us from the United States, that's 1 in 5 children in the United States currently live with a neurologic condition. The foundation operates in the lanes of education for providers and families, for support services, and really for care advancement. So we fund research and really charge forth a federal advocacy agenda to elevate topics that really unite our community. And transition of care is really one of those. If you think about it, really no young adult does not transition to the adult healthcare system. Those, though, living with medically complex conditions need a lot more support and coordination. And so that's really why the foundation, under Larry's leadership, starting back in 2014, took on this leadership role. This is a busy slide, and I'm not going to assume that all of you know all this content or are going to memorize it, but I just wanted to give some sort of energy that there has been a lot of work done already on this issue, and have that energy really motivate today's conversation towards what we could be doing together to drive further impact. So just a little ground setting. Back in 2011, I was very fortunate to be the lead consultant within the primary care community. That's pediatricians, family physicians, and internists, where we joined together and sat in a conversation about the fact there's a lot of talk going on about transitions of care, but there had yet to be a statement, a clinical guideline that really defined what we meant by transitions of care and what was the physician's role in it. Now, that was really within the primary care perspective. When we sat in that conversation, we defined it for those physicians, but then we charged in that statement specialists to really define their role in a co-management sense with the primary care physician. That statement was issued back in 2011. And until 2014, no other specialty really rose to that challenge until the neurology community did. And CNF was the spot that convened multi-stakeholder authoring panel to really give another clinical guideline about what would be 8 core steps that a neurologist should consider when transitioning a young adult. And that statement was published in 2016 in the Green Journal, and it was endorsed by the American Academy of Neurology, the Child Neurology Society, and the American Epilepsy Society. I will tell you that was a defining moment for the neurology community, because unlike any other specialty group that might have issued something from a single disease perspective, we were the only ones that stood together and issued one voice for the whole community. Because of that monumental deliverable, the Child Neurology Foundation then stood up what's called a Transition Project Advisory Committee that same year, back in 2016, with Larry serving as the first chair and now Ann serving as the current chair. That committee was really focused on, let's not just stop at publishing a guideline, let's move forward implementation. And so there's been a lot of deliverables really that spawned from that group, being a clinical toolkit, a lot of family education, and some advocacy initiatives. And now this year, under Ann's leadership, that TPAC, Project Advisory Committee, is pivoting again to really reflect the needs of the larger community on this issue. So now it's really become an expert panel to give more clinical guidance to the foundation staff as we push out more deliverables, as well as to serve as a speaking bureau, as many people are holding conversations about transition of care. And then we're really taking a bigger dive into quality improvement. So how can we really help you in the clinical sense actually do transitions of care? So a big thanks to Larry and Ann for being trailblazers on this issue. And with that, I look forward to hearing what more they have to say. This is a fun group that you're going to listen to in the next hour. A lot of passion, a lot of insight onto this topic. Larry, I'll turn it over to you.
Thank you. And let me just add my own thanks to Amy and the panelists, because we've worked together now for many years. Amy came to the Child Neurology Foundation, as she said, with the background of transition among her other many qualifications. And she has led the charge, and I've only been a foot soldier, and happy to have had worked with so many wonderful people. For those of you who don't know me, and I'm sure that's almost all of you, I'm a child neurologist from the Children's Hospital of Philadelphia. In my over 40 years of practice, I've specialized in complex epilepsy, in the behavior problems of kids with neurologic issues, and in sleep disorders. And during my career, I've also suffered with the families that I've worked with, because I knew that as a child neurologist, I could not continue to take care of them as they grew up. And with the advances in neurology, more and more of them were growing up and facing what we call the cliff, when school finishes, services finish, and it was very, very hard to find providers who offered the same level of care and who even wanted to be involved with our patients. In any case, here we are with major advances like the AADMD, the new committee of the American Academy of Neurology, with adults with developmental disabilities, and more people sharing our image. With that, let me share my slide, my screen. Can you see that? Good. Just wanted to make sure that we're all on the same page about transition, not a time, but a process, a transition that begins at some point, and this has been worked out, that it ought to begin as early as 12 years old or so, not that anybody is moving on, but to prepare and slowly accept the responsibilities of adulthood, and where in our patients with chronic illness or disabilities, to push them to take as much personal responsibility as they can. Whoop. Why I cannot, there we go. So if the goal is to understand and take responsibility, we also have to recognize that maximal independence may be dependent upon intellectual ability, and we may need to have extra input in helping with the additional ongoing educational, vocational, and social needs of people. As you can tell from the CNF, there's been a lot of work done already, and practical deliverables are available for everyone. And the link is down below. There's also autism that has done an enormous job in preparing their children, young adults, and families for the transition to adulthood. This is a very brief summary of the work that was done by CNF in our paper from 2016. Not only should transitions start early, but it should be tracked every year so that we can reinforce the importance of the knowledge base, whatever self-management skills the kids are capable of, and the self-advocacy for both the patient and family. We also know that it takes time to identify adult providers, and that should begin if there's a policy at the local hospital that all children at the age of 18 must move on. It should start a year earlier. If it's more flexible and reasonable, it should still start early so that transition does not become a last minute problem. And it should be apparent that the child neurology team who's worked with the child and the young adult for so long will continue to support the family and the patient, both to understand the expectations of the difference in culture in adult care and the projected timeline. We need to be open with the patient, and of course, the process can only work if we can find the accepting adult providers. Now, there are many, many barriers. The voice of the child neurologist is that we've known these kids often from birth, or at least for many years. And we also are both neurologists and pediatricians. So we see ourselves as comprehensive, collaborative, and we don't take a view of our very fine colleagues in adult care who take care of epilepsy, but not necessarily taking care of other needs that the patient may have. So over the years, the voice of the child neurologist is that we can find few adult practitioners. Fortunately, this is getting better, but we've always found it difficult to find people who are as interested in our complex, often intellectually disabled and behaviorally challenged patients as we. Now, from the voice of the adult neurologist, we know that we've heard that they don't receive the comprehensive, the consolidated documentation of what's happened for all the years when they show up in the office. The patients often do come in with very complex conditions, rare diagnoses, multiple comorbidities, not all of which are common in the adult clinic. And especially for our patients with IDD, they may be unable to communicate effectively. Sometimes they're disruptive. And on top of everything, they often have limited insurance because of their disabilities. We do often, and we did at first, forget the importance of the voice of the patient and the caregivers, although we did incorporate people like one of our panelists, Christina San Inocencio, who will tell you about her story, to hear the voice of patients and caregivers. But what we have heard is that they like our child neurologists, their child neurologists. They've been with them, they've held their hand throughout all the challenges, both of the disease, but also the turmoils of adolescence and young adulthood. And we've heard that the families feel that we as child neurologists have functioned as often the very only primary responsible provider who's managed their schooling, their behavior, their social issues, even more so than the general practitioner. And lastly, we can find, we were told, a knowledgeable, a supportive, or sometimes even any adult provider who can take care. So there are lots of barriers. Again, in addition, I would say that from the point of view of the neurologist, we don't have time to discuss transition. And until recently, there hasn't been a good, responsible guide to help us with all the fragmented care involved in the complex patients. From the family's point of view, they're often happy with us and they don't want to change providers. And unless we do a good job, they don't understand the difference in pediatric comprehensive care and adult focused care. So the cultural differences. From the in addition, there's been a very poor awareness of all the community resources, if there are any, complicated by all the funding changes that happen when kids move out of the pediatric age. And just, you don't have to be in a rural environment, but the transportation challenges are just enormous for people who, like our patients with IDD, are not driving their own. Here are just a couple of stories that are all true in my own practice. One mother insisted that her adult with autism and IDD remain with the child neurologist because he has the brain of a child. Another family of a young man with frontal encephalocele epilepsy, IDD, and aggression wouldn't leave our practice because the neurosurgeon at our institution had reassured the mother that he could stay here as long as he's younger than the neurosurgeon. After many years, I was eventually, at the age of 25, able to transfer a patient to our adult willing epilepsy clinic, but they rebounded within months because the family was told that it was their responsibility to find a provider willing to manage the behavioral challenges that were controlled at the time. I took care of him with appropriate medication. On the positive side, I would say that I had one patient where he had been living in a residential setting, and when three students graduated at the same time, the parents were able to buy a house adjacent to the school and continued to provide services at the school. In other words, they were able on their own to do something that society wasn't able to do easily for them. I want to make one real important point that intellectual disability and the behavioral disorders or neuropsychiatric issues are certainly not mutually exclusive, but rather very, very common, 3 to 4 times the general population. And that adolescence and young adulthood is a time when these issues of mental illness often become much more severe or surface for the first time, like schizophrenia. It is mental illness that is a key driver of morbidity and mortality of people with intellectual disability. And the majority of people with IDD are on at least one medication, and sometimes on as many as 5 to 10. And yet, only according to a pre-COVID report, only 23% of them even have behavioral plans, no less a well-documented transitional initiative. My friend David Dunn from Indiana has said it better than I could. The hardest group of all is the young adults with intellectual disabilities who have neurologic issues and behavior problems combined, because adult neurologists are often not comfortable handling behavior difficulties, while adult psychiatrists aren't as comfortable handling people with complex medical issues. And therein lies the conundrum. However, the work of the Child Neurology Foundation has really gone full steam to provide strategies. And they suggest, and we suggest, developing a team that can look at all of the youth's needs, both medical, psychological, educational, family, and community, and that there should be open communication. We have to try to involve the child and young adult in any treatment plan, and to his best ability or hers should participate and own the plan. We have always suggested maintaining optimism, because many problems improve over time. There's maturity that kicks in. And most importantly, low expectations tend to be a self-fulfilling prophecy. I want to remember that adult medicine is more of a specialty focused. And the other issue, of course, is that parents of kids with intellectual disabilities are also aging. At the same time that there are fewer and fewer resources for them. For those of you in the audience who are adult providers, remember, you're never alone. Even after you've taken on the patient, the pediatrician is always there to confirm successful transition. The child neurologists are always available as a resource, both in terms of understanding the latest advances, as well as the individual patient's own unique problems, and never underestimate the patient. Even the nonverbal ones that I've taken care of are capable of understanding more than they can say, and they can develop good relations with the adult providers and even learn more and more of their own self-management needs. So in summary, transition works when there's a proactive approach. The explicit policy starts in early adolescence and reevaluated annually, and engages both youth and family. It recognizes and addresses all the needs of the family and the youth. The neurologist is not the only one, but he plays a key role and responsibility to oversee the implementation of the plan. And even if, as in many communities, adult neurologists treat younger patients and there is no need to transfer the patient, transition remains an important point, and we need to still understand guardianship, community living, continuity of services, changes in insurance. And despite all the barriers to successful transition, we can do it and we can avoid the cliff. Well, that's where we've been. And now I'd like to turn it over to Ann Tilton, who is going to talk about what has been happening at the Child Neurology Foundation and in the community to improve things. Ann, you there?
And you're muted.
Okay, yes, I'm sorry, I had it on mute, and the little button disappeared, so my apologies. But I certainly appreciate the opportunity to be here, and it's actually very much a privilege to share with you not only some of our passion for transition of care of adults with intellectual disabilities, but all of neurologic patients, and also to share with you some ongoing projects and other projects that have been going on through the Child Neurology Foundation. We looked at this slide just a moment ago, and so I won't go through it again. But so where I'm going to pick up is a little bit later into this 2016 and 2023, and particularly in this transition expert panel. We know Dr. Brown had led us through a lot of this, and some of the evolution, once we put a lot of the toolbox together and other things, was to really see how we could best help with the deliverables that were coming out of the Child Neurology Foundation, and to help with clinical support and quality improvement to drive those efforts. So really what we're talking about is some two-way education and resources. And it's incredibly important, and sort of the secret sauce of the Child Neurology Foundation, that it exists as a facilitator between healthcare providers and those caregivers and children, or actually young adults that are facing a lot of this, along with the disorders that are affecting them from a neurologic standpoint. So the Child Neurology Foundation is really sort of the conduit that gathers information, looks at the things that the caregivers and young adults are really asking about and hoping for, and sharing that with the physicians and other caregivers in order to be sure that we really have coordination and collaboration as we move forward, ultimately creating really a better system for all stakeholders. So transition of care, and I'm going to walk you through some of the improvement efforts, which include now grant administration, patient and family education, and physician education. So let's talk first about grant making. And this is really a new project. And this is the first year that it's come out. So this funding innovation is two $25,000 grants to fund the quality improvement that Amy Bryn spoke about in the efforts of transition of care. We currently have two that have been chosen and are working on this. Lurie Children's Hospital, and their project was using telehealth to connect adult and child neurologists. Also, Boston Children's, they have hired a transition coordinator for young adults with intellectual disability. What they receive from this is that we provide the data through the Child Neurology Foundation and provide it to these individuals and groups that are doing this work in hopes of giving them the data they need in order to improve. And also they have the availability of the expert panel in terms of suggestions and input. The current grantees actually will be presenting at the AAN on the 24th of April, and the current grant cycle is now open again. So if your institution is interested or people are interested, please visit the Child Neurology Foundation website for more information. So what about these in a little bit more detail? Well, there's parent and family education. Not only is there the scholarships and the funding innovation that I just mentioned, but within this, there's also grantee workshops for these people. This is transition of caregiving workshops. So for the caregivers, the parents, the caregivers from those grantee institutions, we'll talk about ad hoc workshops and also transition toolkits. But what's interesting is that this family course, there are two within this. One of them was a 1-hour webinar talking about, or done virtually, talking about caregiving and empowering young adults along with the caregivers in dealing with the transition and their roles in that. Also to provide support and resources to the community. The other is actually a more interactive one where the individuals who are going through transition, be they the caregivers or those going through, can share in an interactive way what they see going on. And then also particularly helpful is to make them more confident in supported decision making. I mean, we do know that autonomy and independence are actually two different things, where someone can express autonomy while still being in a different type of situation where a parent or other caregiver is really helping in a broad way. The ad hoc workshops are a little bit different. Those are one-on-one, we provide one-on-one workshops with national partners. Those could be the local Epilepsy Foundation, that could be the AAP, state councils on developmental issues. If there's a need, then please contact us. That type of support can also go on an ad hoc basis. And then we talked about the transition toolkit, and I'm going to speak to that just a little bit more now. So as we look at this, and this is just the checklist of it, and behind each of these are forms that have already been developed where someone who is developing this can use and pick them. The medical summary and emergency plan is one that I particularly like. With electronic medical records, this is a little bit better, but what a blessing it is when the patient comes in and they have a summary of when their surgeries were, what their medications have been, what they have done in one place. And so it helps them whether they go to an emergency room or whether they come into a new provider. Now, really, it's a real call out for the specifics for people with intellectual disabilities, because there's a self-care assessment within this. And with that, that's particularly great because the young adult can see if the skills have been acquired that they need. And if not, who is responsible for that? Can they take their medicine on a daily basis? Do they know it? If not, then one can say this is who's supervising it. Do they know to call the doctor to get refills? Do they know to go to emergency room in their history enough to really be safe when they arrive? Also, it defines goals, and sometimes the goals are different within the caregiver and the individual. A nice example is that the caregiver may say, well, taking showers isn't as high on my list, where that young individual may say, that's the highest on my list. I want to be independent in taking my showers. So that kind of thing can be defined, checked off, recognized, used internally, as well as used as someone who's providing care for these individuals. So what about physician education? CME for physicians was hosted in November. The content will be hosted. The content is going to be informed by the expert panel that was mentioned. And so it's guidance to incorporate new guidelines and transition resources into practice. There'll be a continuous loop back or feedback loop between the Child Neurology Foundation and caregivers, and really to say, where are the areas that if we haven't recognized them, you need to tell us so that we can find those pain points and really address that. Because sitting from the outside may not really inform us on what we really need to focus on. So transition of care at the Child Neurology Foundation is really a community of support, a collaborator, a conduit of information, and not for one specific diagnosis, but for all within this umbrella. So it's funding innovation, which I've told you about, caregiver support and education, and an arm of both of those is that the physician or other medical provider also receives the education and the information that is gained in this means. So for further information or other resources or anything you would like to tap into, please reach out to the Child Neurology Foundation, or Jessica Nickrand at thechildneurologyfoundation.org is instrumental in, as a staff person, putting together the transition of care information. So with that, I thank you very much, and I will turn this over to Christine, and definitely look forward to what she has to say.
Hello, everybody, and thank you for this invitation. It's such a pleasure to be here. Transitions of care is something that's very near and dear to my heart. And I am going to talk about multiple perspectives on this area. First and foremost, I think, is the perspective of a sibling. And as you can see on the right-hand side of the screen, there's a photo of me and my younger brother, Michael, who has a diagnosis of Lennox-Gastaut syndrome. And for those of you that are not familiar with Lennox-Gastaut or LGS, it's a severe form of childhood onset epilepsy that persists throughout the lifetime and is characterized by typically frequent refractory seizures and developmental delay. So my brother now is 35 years old, and I'm going to start with that sibling perspective. But in addition to talking about our experiences as a family and what had happened to Michael during his transition event, not a process, I'll also talk about the perspective from an advocacy point of view and a nonprofit organization. And then also as an academic, specifically health communication perspective and some of the work that I've done in this area, specifically on more of the patient side, including a qualitative study I did with Child Neurology Foundation back in 2018. And then I'm going to just very quickly revisit the literature today and then bring it all together with these three perspectives and talk about future opportunities. Hopefully that will excite some of you. So this is a funny picture. I love to show it. It's very 90s. This is my younger brother, Michael, standing in front of me. And at the time, he's 4 years old. This was about a year after his first seizure, but a year before his official diagnosis of Lennox-Gastaut syndrome. And then also in the picture is my older brother, who's 2 years older than me. I think I mentioned Michael is 4 years younger than me. So that age difference, I think, meant a lot just in terms of our relationship and me sort of stepping in as a caregiver in its own right. But I'll take this opportunity just to give you a little bit of a backstory as to why transitions mean so much to me. Michael did not have really a transition process, like I mentioned. He stayed with his pediatric provider until he was 25. Our family felt comfortable with her and she felt comfortable with him. But unfortunately, at the age of 18, my parents hadn't received legal guardianship of him yet. And at 18, he started to have some really severe behavioral issues, including a clinical diagnosis of psychosis. And he wound up in a psych ward of our local hospital for some really aggressive behaviors. And my parents had not been armed with the information of transitions, and they didn't know to have legal guardianship for him. So when he was in that situation, he was involuntarily committed, and my parents weren't able to get him out of the hospital. And it was, as you can imagine, a really devastating situation. But in addition to that, I look back at, sort of his teenage years and understanding that the process of him turning 18. And there was never a readiness assessment, or there was never a transition checklist provided to my family. And anything we did know about transitions really came from the IEP. So I think that story is going to set me up for my next two perspectives. Again, I think it'll tie in all together really nicely. So the second perspective is this advocacy perspective. And just to give you some frame of reference, 2005 was when Michael turned 18. So we grew, growing up as his older sibling, I was sort of his, big sister and protector. And I had witnessed, we think, if we could count some sort of assign a metric to his number of seizures, we think it's around 30,000 that he's experienced in his lifetime. So I've seen them and being very close to him. So it affected me a great deal, as you can imagine. But that led me to found the Lennox-Gastaut Syndrome Foundation. I formed this organization in 2007, 2 years after that 18th birthday. And I ran the organization as the director for 13 years. And during that time, I was so closely involved in transitions, not only from the experiences of other families, but being involved, of course, with TPAC. And today, I'm no longer serving as the director of the foundation, but I do work with these other organizations that are rare epilepsy organizations, sort of across the span in terms of severity. And I can tell you all of these organizations and their members still have challenges with transition. So it's not unique to severe forms of epilepsy. It really is just across the spectrum of neurologic disease and disorders. So that is the advocacy perspective. And then finally, I wanted to kind of look at this from a unique lens, not that the academic lens is unique, but specifically a health communication lens, because that is where my training is and where my research interests lie. So during a TPAC meeting, and I think it was 2017, we were sitting around the table and we realized that these conversations are so important to have, but the family should be at the table. And luckily I was the family member at the table, but maybe perhaps there was an opportunity for additional family perspectives. So I met with Amy and Larry and we agreed that, maybe that there is an opportunity here to hear what the caregivers are saying, because from my personal experience and my experience in the advocacy world, I did notice that there was a difference in what the neurologists were saying versus what caregivers were saying was actually happening. I proposed a qualitative study. I was doing my PhD at the time. I'm a qualitative researcher, and I said, let's get some families, let's get their perspectives, let's see what they were thinking. And so I conducted some focus groups, and the focus groups were with LGS families, but also with non-LGS families that had IDD, or the caregivers of IDD individuals. And the goal was really just to understand this perspective, really. And so I gathered the data, I did the analysis, and then I presented it at the 2018 CNS meeting. And so I'm not going to go into all of the data. That's not the point of today's talk, but I do want to just give some high-level findings that I think are appropriate for this talk today, but also that have some implications maybe for some further research. So after I did the analysis, or actually let me skip back for a second, just to give you a little bit of the methods here. There were 24 participants. The ages were from 12 to 32 years, so it was a nice broad age range. All had IDD, 23 out of 24 had intractable epilepsy. So the themes that were identified were, and this might not surprise you, but the first was that discussions on transitions were typically, from the caregiver perspective, lacking in the clinical setting. The second theme was that many of the adult patients with IDD were still being seen in a pediatric setting, and of course, from my experience, that rang true to me. Readiness assessments were lacking generally across all of the focus groups. And then lastly, which is unique, but probably not surprising, that the IEPs were repeatedly mentioned as a tool, or not even a tool, but as a framework that families really relied on to understand the transition process more, even in the clinical setting, which I thought was interesting. So I did just bring up some quotes to support these themes. The first is about the discussions on transitions are lacking, so I'll just read these really quickly. The first quote was, "I think the family should push the doctors to talk about transitioning because it's not happening from the doctor's side." And then a second quote was, "No one ever brought up transitioning until 2 months before his 18th birthday. We had no direction. We went from a pediatric children's hospital to the Kaiser system, and we haven't seen a neurologist yet." So I think these two quotes just reinforce this idea that the transitions were lacking based on the data that I collected. And I'll move on to the next one. The next theme was that many adult patients are still being seen in a pediatric setting. I gave you my example, but there were a few others as well. The first one is, I asked my pediatric neurologist, what's going to happen when he gets older? And she said, nothing, he's just going to stay. I heard this a lot, and I continue to hear this in the rare epilepsy community. Like Larry had mentioned earlier, as much as the physician wants to hold on to the family because they have this bond, this almost, lifetime of experience working together. It's the same for the families in a lot of situations. They don't want to leave that child neurologist. And then the second was, my daughter's pediatric neurologist told us that we could stay there forever. It was her pediatrician that mentioned we need to find an adult provider. So again, just reinforcing a lot of what has been discussed so far. The ready assessments are lacking. There were quite a few quotes on this, but I pulled this one specifically. At 18 years old, the pediatric neurologist said, he's 18, time to find a new neurologist, and the family felt dropped and left depressed, and that was frequent. And then the last was the IEPs. The IEP was referred to very frequently in these focus groups because the families felt that the IEP was almost this guide or roadmap to help them with multiple aspects of transitioning. And even the IEP in some cases had discussed the clinical transition, which I found was really interesting. So where are we today in the literature? Again, I did this study quite a few years ago, but I had reviewed the literature for today's call just to see if anything had really changed much. And some new publications have actually been really interesting, but I wanted to highlight a few just takeaways from my brief review of the literature. So as we know, the majority of the published literature on transitions of care really come from that clinical/provider perspective. The second is that the frameworks and the guidelines and the models, whatever you want to call them, they're fantastic and they can be extremely useful, but a lot of them have not been validated. So there have been some validated, but how as a community, can we take what's been done and really sort of test it or validate it with families perhaps, or with adult providers perhaps? And then lastly, the caregiver and patient perspective is often left out, especially in a qualitative nature. And this is what I'm sort of cheerleading behind too, because I think it's just so important. So as I wrap up, I just want to look at future opportunities. But before I do, I just want to highlight this photo here. As I mentioned, Michael has some behavioral issues and he was very grumpy this day. This is actually, I received an award from the Child Neurology Foundation. This was 10 years ago. It's hard to believe. Michael was not feeling it. He was not having a good day, but we were able to get a picture in front of this sign here as I was presented the award. And I just thought that this is such an appropriate picture to sort of wrap everything up. So in terms of future opportunities, of course, always consider the caregiver perspective and don't forget about the siblings as well. Thinking about this, and I thought this was kind of unique just to propose it, but think about maybe transitions from a health communication lens. This is my area, so I really get excited about maybe looking at what's been done in the patient provider literature for other disease states even, and looking at the models that they've built and what they've done in terms of the validation of those. And maybe there's some things that we can borrow from that field. The third is looking at case studies of successful and unsuccessful transitions from the adult side. As Larry mentioned, sometimes families sort of bounce back to the pediatric neurologist if something doesn't work out with the adult. And it would be interesting to look into that a little bit more and understand why these things happen. And then finally, support the adult providers. Again, this has been sort of discussed already on today's call, but making sure the adult providers feel prepared to take those like my brother who not only have intellectual disability, but behavioral issues and have many more complex needs than some of their other patients. So thank you so much for this opportunity. And I'm always open to hearing suggestions and ideas from everybody based on the presentation I have today. So thank you.
Thanks so much, Christina, and thanks to Anne and to Larry. One of the things I love most about being in the advocacy community is you routinely are drawn together with people because of a need, and the people that step forward to answer the need have a passion about the issue that wants to be addressed. And then you build these beautiful relationships where colleagues then become friends. And it's just really, it's been very nice to kind of sit with the three of you who I haven't seen in a while and see the passion and the commitment to improving our community when it comes to how we can support not just the young adults, but also the providers and the families as they make this transition. We have about 10 minutes left in this hour, and we have a number of really great questions in front of us. So if okay, Seth, you're back on my screen. So I just want to make sure you're not jumping in and saying anything right now. I can go ahead with these questions. Okay.
Go ahead, Amy.
So I don't know, Marcella, but you are rocking it with these questions. Your two questions have hit on two of the biggest hot buttons, if you will, on transition of care that we hear across the country. So I'm going to give you the due and start with the first one. And to Anne and Larry and Christina, this first one really talks about guardianship, which of course we hear a lot about, but in particular, how it doesn't align with really supported decision-making. So here's Marcella's question. I'm continuously told to seek legal guardianship, yet that is the most restrictive form of supporting a person. It's a law in many states, yet most providers in medical settings, as well as educational settings, have not yet caught up with this change. There are many problems with legal guardianship, and there needs to be supported decision-making as part of the transition process. What do you think about this? And what do you think needs to occur to have this become more of a norm? Who wants to take it first?
Well, I'll take a crack at it first. It is true that it's the most restrictive form, but one also has to remember that there are so many of our patients who are not capable of managing their own affairs and need the help. And as we heard from Christina, if there is not some form of legal guardianship and there's a problem, it can blow up in the face of the patient and the family, not always as bad as involuntary commitment, but it could certainly happen in refusal to care in an emergency setting. So it is a conundrum where you want to have empowerment as much as possible and not to minimize what a patient is capable of, but there have to be the legal protections. And this is something that I think needs to be worked out on an individual basis. What makes it even more complicated is that we have different laws in every state that make it more or less restrictive. Anne, you want to?
Well, yeah, I'll jump in as well. I think this is a really tough topic. I make it a high priority when I'm talking to patients and families that I think are going to need that. What I find is every state is different, exactly what you've said, and tutorships and guardianships and all of this language is also very confusing, and it's very much important to have some legal advice, but that too is hard to come by. And what I do know, and I tell the families, is if you do it before 18, it's that you get guardianship. If you do it after 18, you have to prove incompetence. And that becomes a much, much larger lift trying to get that done. Plus, probably pretty emotionally tough in some cases where someone's going to resist it. The other thing that I've come across is that some of the judges or different people want neuropsychological evaluations. So if those things can sort of be worked through, even the school, I mean, if someone's really has obvious disability, then some of the school IEPs and those things you're talking about will bring forth where they're functioning, what levels and all of that they need. But if it's maybe more less intellectual and more behavioral, it requires some of the other things as well. So this is a really tough topic, and but I think it's a priority for the parents to understand that before 18 is critical.
Yeah, I would just add one thing in my experience, that in some states, a patient over the 18 has to have an advocate ad litem in court. And it may be against, in favor of the patient, but against the better judgment of the family, the doctors, and everybody else involved in the child. And it could become complicated and bitter.
And the last thing I would just jump in and say, especially to your point, Marcella, about supported decision making, I don't see that it's an either or. I really don't see guardianship and supported decision making as exclusive, but instead the guardianship, that really is kind of like the science, the technical aspects that we need to put in place to just protect the opportunity to access healthcare. But that decision can be made within a supported decision-making approach or the art of medicine. So the way in which you're approaching making that decision with the young adult as well as the family. It doesn't need to be an either or. Okay, I want to move to your next question. And this one really talks about transition of care modeling, which is, I can go out for hours talking about this. So here's what Marcella asks our esteemed panel. It seems to me that an easier way to address transitions is to have comprehensive neuro care in one clinic, one medical home, where pediatric doctors and adult neuro doctors practice for one roof in one practice. Why isn't this a model? We only have a couple of minutes, but does anyone want to jump in here about transition of care models and respond to Marcella's question?
I will say that some are freestanding children's hospitals and there are adult providers to start with. And that's our setting. So then is telemedicine maybe the part of the answer, that everyone's in the same room, but by different modality. I'll let someone else add.
We're a little bit late in coming to the party. It's been worked out in some ways with pediatric cardiology, where they have services that do combine both the child cardiologist who understands the issues, the unique issues, and the adult adult cardiologist. But we have very few similar approaches that I've ever heard of. And it would be wonderful to live in the utopia that Marcella describes.
Amy, can I add one comment?
Yeah.
Hi, this is Seth Keller. I was going to come in a second. I'm an adult neurologist. I'm on the passing the baton to the adult provider side, so I get it. And I think really what it is, from the question that was just asked, there are the development of certain transitioning clinics that are what they are, where there's a combination between the pediatric neurologist and the adult neurologist in the same. So it's like passing a baton from someone within the same room, the same building, the same clinic, which makes it so-called easier. But that's so small and it's not like broadly looked at. That's definitely just, I wanted to bring that one thing up also in this question.
Yeah, thanks for that, Seth. And I'll just wrap this up before I turn it back to you, Seth, for your closing comments. I would say I've had the privilege of working on transition care now for over 20 years, and there's definitely that reflex of this is a huge, gnarly problem, and we want to solve it, and there's got to be a silver bullet. And so we will think always about, is there that one model? And what I would say after 20 years is there is not one model that's going to work for all, not all patients and families, not all providers, not all states, not all institutions. And so that's really one of the reasons why the Child Neurology Foundation is starting to fund these innovative grants, because we really want to highlight models, various models that are working, so that providers and families don't feel like they have to have, you know, that silver bullet, but they can look to what other communities have done, and hopefully have some sort of modeling to follow. So with that, I just want to again thank Larry and Christina and Anne for a wonderful conversation. I want to thank, we've had nearly over 100 people join us for this whole hour. I haven't seen anyone tick off, so I really appreciate that. And just know that if you are that's really facing the issues of transition of care, please know you feel like you can reach out to us at the Child Neurology Foundation. We stand with you on improving the way that we take care of these young adults and their families, and you all as their providers. So with that, Seth, you want to take us on home?
Yeah. Thank you very much. Yeah, I see Grant came out. Grant, I wanted to thank you first for helping to create our series. Grant has been our major person who's been helping support these events. And really, again, I'm an adult neurologist. I'm past president of the ADD. I helped chair the AN's adult IDD section. And the reason why we have this webinar and the other webinar is because of this issue of reality and the difficulty of the adult provider not knowing what they don't know. That's why this is going on. This is why we have this educational series, because we know that we need to educate and train. There's a lot we need to learn, but we're also working together and definitely working with the Child Neurology Foundation, not to butter Amy up, or certainly Anne and Larry and Christina. I mean, really, this is a kinship, this is a friendship, this is a way of working together. And definitely, we've also been working with ILAE too. This is not just an issue that stopped at the borders of the United States. This is a world issue and a concern we have. So definitely, we want to thank everyone for coming on. We have other archive series webinars that you may have not seen earlier. We have another event that's coming up by our other colleague, Danielle Andrade, coming up on May 22nd on the importance of genetics. You've heard of genetics. So genetics is going to be a very important discussion that we're really going to talk about. So stay tuned for the announcement of that webinar. And I definitely want to thank my AEDM team who's behind all this, working to kind of make this look showy and look good and really put on a great production. So thank you very much for the ADD and the team that they've done. And again, this will be archived. With CME credits will be provided. And again, thank you very much. And also Jazz Pharmaceuticals finally for the very generous unrestricted health grant for us to be able to put on the series. So again, thank you all. Thank you all. Thank you all. Grant, any final words? I mean, I appreciate any final comments.
I mean, I think you covered it all with that, Seth. I think we're good. Just thank you to our speakers, thank you to our audience, and we look forward to May 22nd at noon when we have Dr. Andrade speaking on genetics, epilepsy, and IDD.